Yeah, so this is lecture 12. 11 does come before this, so I'd advise watching that maybe over your Thanksgiving break. If you didn't have enough to be thankful for, you get to also watch that video. That was the introduction to the epidemiology section of the course. Like, this is kind of the focus of part 2 of this course. We're going to continue on with that. So that was covering kind of basics of, what are the aims of epidemiology versus strictly looking at biostatistics. Now we're going to be looking at some of our data sources for how we make up some of these epidemiologic studies, and then also looking at how we measure some of these. So we'll go over this we kind of already talked about during the journal club, so this will be directly relevant to that. So hopefully you remember the journal club we did a few days ago, right? Hope so. Okay, so let's look at some sources of health data. So when we did that journal club the other day, where did they get their data from? CDC, yeah. And so you're going to find that a lot of times the data that we're getting for a lot of these studies both comes from the CDC, which is more of a national organization. How about locally, if I just wanted data from Florida about health information? The health department would be really good, right? So again, the state health department is usually a big source for a lot of these, and they communicate with one another to kind of help each other out as far as like getting data, both at the state level and communicating up nationally and vice versa. So that can be very, very helpful there. Also, we can get information, from things like the census data. Anyone know how often we do the census? Every 10 years, right? And so that's going to be coming up here pretty soon, which is going to be really important, to make sure we get an idea of where the country is going for population goes and things like that. Now, when we're looking at some of this information, when you're considering the denominator, when you're trying to look at, risk for things occurring or the rates for things occurring, as we'll see, what do you consider the denominator to be? Basically going to be the total number of people at risk for an event happening, or the population that you're looking at, right? So if I was going to be looking at the rates of stress ulcers in PA students at Nova Orlando, my denominator would be 60 right now. He's 60. And so we would go ahead and say, okay, anyway, it would basically be any person in this room that would be at risk for developing the condition we're talking about, right? And so then the numerator would be the people who develop the stress ulcers, right? So again, that would be the case where the numerators of people actually had the outcome that you're looking at, or were at risk for the particular thing, had the exposure you're looking at, whatever you define it to be in these cases here, right? And so if we're looking at things like, the rates or the number of people at risk for dying, we can look at things like death certificates. We can look at things like birth certificates if we wanted to look at the number of people being born. Things like that can all help us out kind of defining both what our denominator and our numerator is going to be for a given event. So as I mentioned, the census gets done every 10 years, and that helps us out with getting ideas of kind of the characteristics and the number of people within the country itself. Is that data always going to be 100% accurate? Why might the census data be inaccurate? Does everyone get counted? If you have people who were maybe not being reported, or people who were not maybe turning in census data, things like that, sometimes you can have underreporting of things, or people may fill out the data incorrectly or lie on it or something like that. So it's not always going to be perfect. No data set is, but hopefully we can get as close as we can with some of this data here. And this is where we're going to get a lot of information as far as looking at denominators for things like birth rates and death rates, et cetera. Right? So this is just one example of health data we may be pulling for some of these studies we'll be looking at. So, and again, looking at things like, infant mortality rates, that's usually information you can get pretty easily, where you can look at the actual birth certificates that are being filed. A lot of times that information is usually pretty well reported for the most part. When do you think, a birth certificate, when might someone not be accurately counted in that sort of rate there? If you're looking at infant birth rates, who might not get a birth certificate? Maybe you're born outside of a hospital, and then no one ever actually filed the paperwork for you, or something like that, or things like that you can consider, where the data may be underreported. But for the most part, things like infant births are pretty well documented, and it's very helpful. Why do you think we look at infant mortality rates and things like that as far as looking at the overall health of a country? Because usually it looks at, how well we're taking care of the moms when they're pregnant, and then how well the baby's surviving and things like that. And that's usually pretty useful for comparing data between country to country to see kind of what the overall health is. And so when you talk about, the health of the United States versus other countries, oftentimes they look at things like infant mortality rates, et cetera. We'll talk more about that towards the end of the lecture here. But again, just kind of giving you an idea of different sources of this information, where you can find these things and where some of these studies might be pulling their data from. So, as I mentioned here, that a lot of this data collection comes from both the local, the state, and then also the national level there. Looking at things like, birth certificates, death certificates that get collected locally and then kind of get transmitted up, right? And so, for instance, looking at things like birth certificates, usually completed by the physician or the provider who's going to be kind of being overseeing that patient there. Who do you think might be doing death certificates? So it could be a physician, right? Who maybe the patient dies at the hospital. Who else could be doing that? There could be coroners. There's medical examiners. Anyone know the difference between a coroner and medical examiner is? Yeah, I didn't know this either for a good long time. Actually, I went to the medical examiner's office in Orange County and learned a lot about it from one of the doctors there. Actually, a medical examiner is a physician, right? So they actually had to go and have specialty training in pathology and all these things. A coroner actually can be someone who just has like a certificate. Like they actually don't have to have any medical background whatsoever. In some cases, they actually are elected officials. So if you're ever listening, if you were to say like who has a little bit better say on what the actual cause of death of a patient is, like usually the medical examiner is going to have a little bit more credence to that because they're actually a physician. But again, this is where we get some of this information that kind of gets transmitted up to give us an idea of like what's happening at the state level or at the local level or even the national level. And so again, a lot of times we can find that by using some of these national sort of sources of data here, either the CDC or sometimes we use things like the National Center for Health Statistics. They can give us a lot of information, kind of what's happening more on the national level. We actually use a lot of this data from the health department. We actually coordinate a lot of that with the poison centers, right? So the poison centers are kind of nice because we're able to take calls from the lay people kind of in real time, and then we relate that all back to the health department. So we can look at things like, if there's new emerging drugs of abuse. So anyone remember like bath salts when they were kind of becoming an up-and-coming thing a few years ago? Like the poison centers were the first one to get calls on that because we'd have ER physicians who were calling us up at the poison center saying, hey, it's patient overdose on this stuff. It's called white rush or white lightning or something. We have no idea what it is. And then we're able to report that to the health department, and that goes up to the CDC, and they're able to look at these things from an epidemiologic standpoint to say, hey, is this an epidemic? Is this something that's happening kind of out of the usual rates you'd normally expect? So again, very important that we have the kind of good, quick communication between these different levels of government to make sure that we can kind of find and identify these problems and be able to kind of report on them pretty expeditiously. So as I mentioned, the census gets done every 10 years. So 2020 will be the next year that we actually have the census being done here. And again, this is also useful for helping us with like population projections, kind of getting an idea from 10 years to 10 years, seeing like how things are going to be progressing. Also looking at the demographics of the country and seeing what direction we're kind of heading in those cases. So usually what you're going to find is that when you're looking at clinical epidemiology, and this is going to be something you're probably going to be more focused on as it pertains to like individual patients, typically you're going to find that a lot of the data comes from either examinations of patients, right? We can look at things like, clinical records. So actually looking back and looking at the records to see, what were the courses or what were the diagnoses that are being made over time, things like that. And then actually looking at studies of specific clinical populations. So for instance, when we were looking at that journal club, like what was our population we were looking at? Like middle and high school students, and so again, that was the population. We had that study that was done based on surveys, and we were able to take that information. They were able to do another study based off of that surveys that were done there. Now, the nice thing about using these databases is what? It's pretty cheap and easy to run studies on, right? So for instance, that study was done by the CDC is kind of an ongoing survey they do. But if you had a good idea for a study you wanted to run using that data, you can go and just request that information. There's probably some formal process to get that, and they would send it to you, and then you could run your study, right? You could run your own statistics on it. And so again, it's nice because that helps to speed up the process of getting some answers. Now again, what was the problem of using those databases? Could we show cause and effect? No, we can show correlations though. We can show trends and things like that that may be useful for helping us to design further studies that can help us with a more causal sort of relationship there. So again, as I mentioned, oftentimes that the information that we get is only good as what's actually being recorded there. So again, you have to think a lot of times that things tend to get underreported in a lot of cases here. So for instance, when you're looking at things like, for instance, the National Association of Poison Control Centers, like we send out a report every single year talking about all the poisonings that are reported to the poison centers. Do you think that includes every single drug overdose that happened in the entire U.S.? Well, oftentimes it doesn't, because again, if a doc never called in a case to the poison center, or if, for instance, a patient overdosed at home and they were found dead in the home, like oftentimes that does not get reported to us. So there's always limitations to these studies, but it's important to kind of understand, what the data set is, where they're collecting the data from, and kind of what implications that has as far as any limitations go. But again, if you had information like unreported births and deaths, inaccurate death certificate diagnoses. So, for instance, how do you think that may happen? How can you have inaccurate death certificate diagnosis? If you had no idea what it was, you're like, I don't know, like unspecified causes or something, right? You could have cases where people are dying and the actual cause was never really identified, which may be underreporting, certain things. So, again, your data is only as good as what's actually collected and how accurate it is in the first place. So again, looking at things like the National Notifiable Disease Surveillance System. So there are certain diseases that the CDC actually considers to be mandatory reporting. Anyone know any cases of mandatory reporting diseases? HIV is a good one. Why do we care about looking at that? Because it's a big public health issue, right? So again, you want to be able to track these sorts of things to make sure that you don't have cases of outbreaks of things. For instance, looking at normal rates over time, if you see that all of a sudden you're starting to see a spike in new cases of HIV being reported in a certain population, you want to figure out why that is, right? And so if you take that information, the CDC can then send people out to actually go and investigate to find out what the heck's going on. Or for instance, what's the problem with a lot of, with people moving more towards being more anti-vaccinations? What do they see happening? See cases like measles and things like that are starting to pop up. Like, we can look at trends of that sorts of things to see, like, okay, well, what the heck's going on here? Is it because people are being not vaccinated well, or is it because the vaccine's not working very well? Like, what's actually going on in these cases here? So that's another big thing. Anyone know where the CDC is located at? It's in Atlanta, Georgia. So if you remember first season of The Walking Dead, actually went to the CDC, right? So again, if there was a zombie outbreak, I imagine the CDC would actually be one of the first people to help us, with reporting that. And they actually had a pretty interesting campaign they did. It was like a zombie response kind of thing. It was a little tongue-in-cheek, but it was basically trying to give you like general like prepping instructions for national emergencies and weather events, but in the context of zombies, which I thought was kind of interesting. But anyway, but you'll find that there may be some variation in reporting diseases from state to state, but generally there's a big list of things that get pretty routinely. So I'm not going to go over, and you don't have to memorize this entire list, but just know that some of these things are things you want to consider. So for instance, if you had a case of, let's see, what's a good one? Smallpox. Does anyone get smallpox? I sure hope not. It's one of those diseases that will be eradicated completely, and actually no one even gets vaccinated against smallpox anymore. But it's one of those things where if you had a case of smallpox that showed up, even one case, is that an issue? That's something of like national concern, right? So it's just like, okay, well, what the heck's going on? Because that could be a potential cause for biologic warfare, right? So smallpox could be weaponized and used against a population. So this is one of those things where that would definitely be reportable. You definitely want to define it. So that makes sense, because that's something you would never actually see, and if it did happen, you'd be very, very concerned about it. How about something like hepatitis A? Would you necessarily think to report every single case of hepatitis A? It's a little bit more routine than something like smallpox. You may not think about it. So what you tend to find is that things that happen pretty routinely or a little bit more commonly, they tend to get less kind of scrutiny and they get less reporting. So you may find underreporting of a lot of those things versus something that would be very odd would definitely get reported. Or for instance, imagine when Zika virus is a big deal. You better believe that every single case of Zika virus was investigated and reported on, because it was a big deal. It was something that people had never really dealt with before. They're very interested in it, and so we were capturing those cases much more readily than something that you may not even have on your radar nowadays, right? So again, Zika you wouldn't necessarily think of off the top of your head, and when you're investigating a patient presenting to the ER, for instance. But as I mentioned, usually only a fraction of the cases get reported, but typically we're looking at things over a trend of time to see, are the average numbers kind of changing, either going up or down as the case may go on. But, again, imagine if you saw something like a paralytic poliomyelitis, that's probably going to get reported, because that's something you would not see too frequently. But in some cases, you may have things where there may be a hesitancy to report. You worry about reporting that someone has HIV, because that could be isolating them socially, things like that. What if you actually never even made the correct diagnosis in the first place? Obviously, you can't report it then. But as I mentioned, less serious and more common things tend to get underreported. But again, we can still look at those trends over time to see are things going up or down significantly, and that can maybe cluing us into something going on at the more kind of local level there. Okay, there are other things we can look at. So for instance, we can look at behavioral risk factors. When looking at behavioral risk factors, what do you think that means? Yeah, like drug use, right? So you look at illicit drug use, or maybe we could look at like prescription, non-medical prescription drug use. What else? Smoking, alcohol use. You could look at things like, obesity, things that are more kind of behaviorally related that could be affecting health there. You could look at things like exercise, drunk driving, whether you're using your seatbelts, things like that that can be very useful information, especially when you're looking at from a public health standpoint, how you want to educate people and how you want to maybe focus your time. So for instance, we were looking at that study the other day. What was kind of the takeaway from that, from a public health education standpoint? Remember, we're looking at early use of cannabis versus early sexual encounters. We saw that maybe that would be a good time to try to hone in on some of the education there, especially kids less than age 12, because we saw if they were smoking cannabis earlier than age 12, then they were more likely to have these early sexual encounters. Maybe that's an at-risk population I can gear my education towards, versus if they're older than 15, really didn't make much of a difference, right? These are things you can consider from a behavioral sort of standpoint there. And also, if you look at this one right here, look at the Youth Risk Behavior Surveillance System. That's the exact one that we were talking about in that study from the other day, right? Hopefully everyone remembers that. Okay, that's all right. You can go back and watch that video all over and relive the whole thing. Anyway, other information that can be very useful, information from third-party payers. When I say that, what do I mean? Yeah, insurance companies, right? Because again, it's in their best interest to track a lot of these things. They're filling a lot of these claims. They're paying for things. They want to keep track of these. So you can look at things like Medicaid information, Medicare, Kaiser Permanente, which is a lot bigger out west. The VA is another big one that takes a lot of information, especially from vets and things like that. So again, all the information is out there, is available for use in some cases, and so it could be very easy to get that information and do studies on that sort of thing. And that's where you see a lot of these studies coming from. Okay. So that's kind of where you may see some of this epidemiologic information coming from. Let's look at the actual measurements and how we can use this information. So looking at frequency, what does frequency mean? Yeah, kind of look at the how often something's occurring. You can look to see, lots of different outcomes, right? This could be disease, could be death, could be injury, could be birth, could be whatever you want it to be. But again, why do we care about frequency? Defining how often something's occurring. We can see if that is occurring more often now, less often now. We can look to see how interventions are changing, how the frequency of things occurring. So it's good to get an idea of like how often something's occurring to be able to compare it and see how things are changing. And so we kind of alluded to this when we did the journal club, but we talked about the case of incidence and then prevalence. What's the difference between the two? Incidence is going to be new cases that are popping up. Prevalence is existing cases, and that's going to be at a specific, over a period of time or a specific time point. Prevalence is going to be at a very specific slice of time, right? We're going to talk about that in more detail, but basically that's called a point prevalence. But again, incidence is going to be over a period of time. What are the new cases that are popping up of a given outcome, right? So again, when people switch from, say, healthy to ill, they switch from injured or uninjured to injured, alive to dead, whatever the case may be, when that new definition has been encountered, that's the new incident case, as the case may be. You may hear a little bit of difference where people are talking about where they're talking about incidence rate. We'll talk about rates a little bit later. That definition changes a little bit, but just know right now we're just talking about incident cases. There's going to be cases that are newly diagnosed as you go forward in time. And I'll show you some pictures to kind of give you an idea how the two compare. Prevalence, as I mentioned more specifically, point prevalence is what happens when you're looking at a specific point in time, how many people actually have that outcome that you're interested in. So going back to that case of stress ulcers in PA students at NSU Orlando, if I were to take you as you were entering into the class last summer, and I would take how many of you had a stress ulcer at that time, hopefully none of you, but how many other people had it, that would be the point prevalence at that point, right? And if I took it after the fall semester, that number's probably gone up significantly. I'd imagine, okay, that's my new point prevalence, and I could do it at the end of, say, rotations, so hopefully a lot less, and get a new point prevalence. So again, just looking from point to point to see how often or how many people actually fit that diagnosis. And again, we'll talk about prevalence rates a little bit later, but just know we're talking about point prevalence right now at this point here. So there's a little bit of difference between point prevalence and what we call period prevalence. And I'll show you a picture of that in just a moment to kind of see how the two compare. But basically, when you're talking about the term prevalence, typically you're referring to point prevalence. You're just looking at one slice of time. Period prevalence would be if you were to take initially the point prevalence and then looking at new cases, new incident cases over a period of time. And this will make more sense when you look at the picture here in a second. But basically, it's kind of a mixed thing where you're actually using incidence plus a point prevalence together to get that period prevalence. So let me give you an example of this. So we're going to get, again, this is better than a pictorial sort of example, so I'll show you here in just a second. But basically, this is the slide's going to show you this concept here. And basically, there's going to be 8 different cases we're going to be looking at, and they're just numbered 1 through 8. You're going to see that when the line starts is when the person actually gets diagnosed with whatever outcome we're looking at, and then when the point ends, they've either gotten healthy again or they died. Okay, so whichever one occurs first. And so we're going to look at 2 different time points here. T1 is going to be the beginning of the study, and T2 is going to be the end of the study there. So looking at this, if you were to have someone who, say, enters into the study who already has the definition of the disease, whatever we're talking about, they will already have a line at the very beginning here. So if you're looking at the point prevalence at T1 here, how many people fit that bill? So point prevalence, just looking at T1, how many people actually have the disease we're curious about? So in this case, we'd have patient 1 fits would be a prevalent case. Patient 2, who else? 6 would be, and then 8. Now let's say we want to do a point prevalence at, say, T2. Who would fit that bill? Well, patient 1, because they still have the disease, right? Their line has not ended yet. Patient 3, who else? And 5, right? So we'd have a point prevalence at T2 of 3 out of 8. Versus in the beginning here we had 4 out of 8, or 50% roughly. So looking at this, you can see that in this case here with person 2, they actually entered the study with the disease, and at this point they either got healthy, or they did not have the disease anymore, or they died. Okay. In this case here with person 4, they did not have it at the beginning of the study, but they developed the disease, and then they either got healthy or they died. Okay. So again, in this case, point 4 here, you consider this a what? We consider more of an incident sort of case, right? Because it's something that developed over the time period that we're actually looking at, okay? And so again, what would you say the incidence is of this disease going from T1 to T2? Again, this is all new cases. So you'd say person 3, person 4, person 5, and 7. Does that make sense? There'd be new incident cases that developed during the study period there, okay? See how the incidence and prevalence kind of differs a little bit with definition? Okay. Looking at this, as we see with case number 1, the patient was ill the entire year. So again, T1, T2 is basically just 1 year. You see that they were either alive and still ill at the very end of the study period, right? So they kind of had the disease the entire time. They never got better. They never died. 2, 6, and 8 were people who were ill when the year began, but they recovered or died during the year. So that's why they were not counted at that period prevalence at T2 at the end of the year there. And then 3 and 5, they became ill during the year, but they were still alive and ill when the year ended. See here, like 5, they got diagnosed here, but they still had the disease at the end of that. And then 4 and 7, they became ill during the year and then either recovered or died during the year period. So you can see 7, they got diagnosed and either got better or died. Again, I was talking death. This is going to be a little morose, but it's okay. This is epidemiology. Yeah, life happens. Death also happens. So looking at this, we can look at some different factors here in regards to incident and prevalence here. So again, looking at the 4 incident cases that we already described, 3, 4, 5, and 7 fit that bill, right? So again, these are newly diagnosed cases during the time period here. So these are incident cases that were discovered, okay? Now the point prevalence at T1, as we mentioned, was 1, 2, 6, and 8. That makes sense because they already had the disease right at the starting point on January 1 there. The point prevalence at T2 was again 1, 3, and 5. That makes sense. Now, where you kind of mix the 2 together is where you get that period prevalence. And so that's where basically you're looking at the number of people who had the disease at time 1 and then the new incident cases added on to that. So in this case, it would be what? Or the prevalence, point prevalence here at T1 was 1, 2, 3, and 4. And then what were the number of new cases? So 1, 2, 3, and 4. So you just add 4 and 4 together, and so it was 8, or basically 100% would be the point prevalence here. Or I'm sorry, the period prevalence at this point. Make sense? Now again, what's the thing to note here is that the outcome can only happen 1 time to each individual person, right? So we'll talk about in cases where you can have things happen multiple times. But again, if you're looking at something like life and death, death typically only happens once, right? That's your James Bond, right? Sometimes you live twice, but so that's good for things that only happen once and then that's it. However, we'll look at some cases later on. We talk about things like incidents, like clusters of incidents, where you can have things like a cold, or you can have something like ear infections that can happen multiple times. That gets defined a little bit differently here. This is good for just kind of dichotomous, sort of yes/no sort of things here. You can just picture and kind of again showing the same thing. Okay. So going back to frequency, again, we're looking at the relationship between incidence and prevalence here. This is a good example looking at the kind of tracking aids early on and the kind of the genesis of the disease itself. So again, looking at data being reviewed from the CDC, this is actually information using AIDS data from 1981. when it was first discovered up through 1992. I'm not going to ask you to raise your hands to see who was actually alive in 92. I don't actually want to know. It'd be just disappointing. I was 7 at the time, so it just makes me feel old. Anyway, so what you're actually going to find is that 92, the definition for AIDS changed pretty drastically, and so we're going to look at the incident cases of that in just a little bit. But what you're going to find is that definitions are really, really important when you're looking at things like incidence and prevalence, because if I define it differently, what could happen to my rates of disease? It could either go up, it could go down. As diagnostics get better, you get a better idea of actually who has the disease or who doesn't have the disease. I mean, back in the 1800s, do you think they could diagnose a myocardial infarction? No, everyone died from like indigestion. Right? So this is one of those things where the definitions can change greatly over time, and so it's hard to compare apples to oranges in those cases, because as the definitions change, you can't really compare the two together, as you'll see. But anyway, what we're looking at in this case here is going to be all the cases, and again, the first diagnosis of HIV/AIDS was made back in 1981, and then this data was up through 92 when that definition actually changed here. So each of these boxes here would be during that year the number of incident cases that were diagnosed, okay? The dark gray portions of the bars are going to be the people at the end of the study period at 92 who were dead. The white portions of the boxes are going to be the people who were alive at the end of the study period. Okay? So in this case, if you were to say add up all these white boxes here, all those people at the end of 92, that would be actually your prevalence of disease at that point. That's that point prevalence of all the people who are still alive with HIV or AIDS. Now, what do you kind of notice about these early periods here? Were a lot of them still alive at the end of the study period? No, a lot of them were dead. How come? We didn't know what we were dealing with. We didn't have good therapy. We didn't have good supportive therapy for these patients. But as you see, as you get later on, we start to introduce things like antiretroviral therapy, like azidovidine and things like that. You just notice here that the percentage of people who were still alive at the end of the study period were either diagnosed right that year, so they were very early on the disease, or especially back here, where they were getting better therapy, and so a lot more of them were actually staying alive. Okay. So again, looking at each box would be the number of incident cases for that year. But when you combine all the white boxes at the end of that study period, that would be the actual prevalence of the disease right at the end of that study period. Okay. So in the full height of the box, there's the number of new cases that were diagnosed, the darkened portion of those that were dead at the end of that period at 1992. Okay. And then the white space of those that were still alive. And so if you were to add up every single white box there together, that would be your prevalent AIDS cases at the end of that study period, December 31st, 1992. Make sense? So, as we mentioned, if they were diagnosed between 90 to 92, they were probably a little bit earlier on in the disease process than if they had been diagnosed, say, back in 1985. And so because of that, they were probably early on, probably less likely to die at that point versus those that had been diagnosed earlier. And again, as the treatment got better, as we're starting to introduce antiretrovirals, people were starting to live a little bit longer there. And so again, back in the day, when they were first diagnosed, a lot of those patients ended up dying within that first 6 years, just because we didn't have a lot of really good therapy for it. It's kind of crazy to think how we've kind of revolutionized that therapy just say in the past 30 years or so, because nowadays, are most patients with HIV, are they dying off super early? No, a lot of them are living a lot longer, and now we're actually having to live with some of these sequelae of things like the drug therapy and a lot of other kind of chronic conditions they're dealing with. And I'll actually look at that, how that changes prevalence in just a little bit here. But anyway, but again, looking at that total number of cases over a reported time, that would actually be considered to be called cumulative incidence. If you combine every single patient, every height of those boxes together, that's called cumulative incidence that happened during that study period. So, as we mentioned, when the definition changed, actually looking at the numbers here, you can see that the close of 91, the prevalence of AIDS in those patients were 73,000, basically taking the number of people who had the incident cases minus the people who had actually died during that study period, and kind of the leftovers, all the people who were left still alive. And again, had those study been carried on for longer, as more and more of those people died, they would also be taken out of those prevalent cases at that point. Again, just showing the same thing here. So as I mentioned, in 93 is when they actually changed the criteria. So as the definition changes, it's hard to necessarily include a lot of those patients in there before. And so what you're going to find is that there may be a lot of patients who maybe didn't meet the disease definition before, and now all of a sudden they're now being diagnosed as having HIV and AIDS. And so what do you think happened to the incidence of AIDS during that year? Now that we're better able to identify who has it, the number probably goes up. Now, is it actually the case that a lot more people had AIDS now than they had before? No, we could just now catch it better, right? Because we changed the definition. Now we could say, okay, yes, you have HIV/AIDS. Whatever the definition happened to be at that time at 93, they say, yes, okay, now we can diagnose a whole lot of new people with it. It's not that the actual prevalence has changed all that much. It's just the fact that we can now catch these people, earlier on potentially. And so it may look like the incidence has gone up, skyrocketed, but really it's just the fact that we can catch it better now. And so again, it's hard to kind of compare those incident rates before and after because the definition changed so greatly. So if you look at it here, you see here late 80s going up through the 90s, all of a sudden 93, boom, kind of skyrocketed. And again, that's because the definition changed. We're able to capture more people to say, yes, you actually have the disease that maybe they weren't capturing beforehand. Okay. Now looking at prevalence, you're going to see it's kind of the result of several factors here. So one's going to be the annual number of new cases, right? The new incident cases that get diagnosed those years. It also can depend on both the immigration and the emigration of patients with a disease, right? So some people are going to come into the population you're concerned about, people are going to be leaving. So that's always going to be changing as well. And then also looking at the average duration of disease will change as well. So for instance, if I have better treatment for these patients and they're living for longer, what do you think that does to the prevalence of disease? Probably going to go up, right? Because again, they're living for longer, so they're there to be counted from year to year, right? And this kind of makes sense when you actually look at the equation here. The prevalence is going to equal the incidence times the average duration these people are alive for, or the average time they actually have the disease. So when the incidence goes up, obviously prevalence goes up, but also if people are living with that disease for longer, prevalence also is going to go up additionally, okay? And a lot of times it's going to be based on better treatment. People are staying around for longer. So for instance, the number of people with coronary artery disease is probably going up because now we can treat these patients better and they're living for longer. So now typically you're going to find that this is going to work better if the incidence of the disease and the duration are stable over an extended period of time. You don't have things like rapid definition changes or new diagnostics or, say a new treatment that radically changes how long these people are living with this. But again, as we mentioned with the case of AIDS here, you can see that the prevalence increased because one, it could be the increase in the actually yearly number of new cases, or it could be just due to the fact that as we have patients who are living with this for longer, they have a longer time period they're actually living with the disease there, right? So, and again, typically when you think about HIV/AIDS, you actually think the new incident cases is going up or down at this point? If anything, it's probably going down, right? Because again, we have better prevention, we have better therapy, we have a lot better means of education about the disease, and a lot more people know about how it actually spreads and how to prevent it and things like that. So the actual incidence is going down, but again, the duration these people are living with the disease is going what? It's going up because antiretroviral therapy is actually really good right now. We can actually keep these patients around for decades instead of them getting diagnosed and then dying within 6 years. So because of that, the duration they're living with is a lot longer. So the prevalence is going to go up, even though the new incident cases are actually going down, if anything, right? That makes sense? Okay. So again, another good example, as I mentioned, was kind of cardiovascular disease mortality. Now, again, we have better therapies. We have more people getting to the cath lab. These patients are living for longer with coronary artery disease. They're not necessarily dying immediately because of it. And so because of that, the actual prevalence of the disease is going up, even though patients are living for longer, right? So again, even though the prevalence is going up, it's actually a good thing because they're living longer. Okay, so getting into talking about risk, what is risk? Besides a board game. So again, it's going to be basically the chances of something happening over a given period of time, right? So again, what's your 1 year risk of getting into a car accident? There's some percentage associated with that. Or your risk of developing a heart attack, or a risk of developing anything, right? So again, that's going to be risk. So, and again, getting back into talking about the numerator and the denominator, that's going to be important, right? To kind of defining what each of those are going to be. And so we're going to looking at the risk event. It could be anything we define it to be, whether it's going to be death, whether it's going to be getting the flu, or it's going to be getting anything at all. And so basically what we're going to be looking at, usually is going to be looking at a population, usually what we consider to be a cohort. We're going to look at them over a period of time and then determine how much of that cohort actually had the outcome I'm looking at, right? So again, and then that percentage is considered my risk. So if I looked at the number of you who developed a stress ulcer during PA school, you're my cohort, and then looking over that year period, let's say, how many ever got a stress ulcer? That's now my risk, right? So I could then apply that maybe to the next cohort that comes in and say, well, they had an 8% risk of developing a stress ulcer, maybe higher, maybe like 80. And then apply that to the next group of students and say, okay, well, maybe you should start taking some PPIs because I don't want you guys to get stress ulcers too because I know your risk is high, right? Or just don't take my pharm class, and then usually alleviates a lot of that. But anyway, so again, looking at this, you're going to find that the time frame really makes a difference because looking at a 5-year risk of death or looking at a 1-year risk of death, you're going to find that the population can change over that period of time. And so it's important to take that into consideration there. Basically, typically your denominator is always going to be the number of people who are entering the study at a given time frame. So that number shouldn't necessarily change a whole lot when you're just looking specifically at risk. So you have to be careful when you're actually applying risk estimates. Typically when they get derived from population averages to an individual patient. So for instance, say a patient needs to go to surgery, and you say that surgery has a 1% mortality rate. And so you're telling your patient, you're like, oh, well, 1% mortality rate that you're going to die from this. Is that a good way to frame it? The patient's like, well, I don't want that. I'd rather have whatever I'm going to have without the surgery there, right? And so you have to be careful. Maybe you could reframe it. Your chances of survival are 99%. Is that pretty good? That's pretty good, but maybe still sound a little too risky there. And so again, because people don't have a hard time really kind of associating these numbers with actual probabilities there. So for instance, looking at what was that Mega Millions thing recently? It was like, how much did it get up to? It was like $1 billion or something like that recently. All these people are waiting in line for hours and hours and hours, and like, you never know, it could be me. It could be me that could get it this time. And it's like, no, it's not going to be you, right? The risk is so infinitesimally small. I read something that said the chances of actually winning that, where if you put your finger right at the equator of the Earth and then spun it and randomly getting a 13 centimeter length of land to get your finger right on the 13 centimeters to actually win. Like, is that infinitesimally small to win that thing? But people are like, you never know, it could be me. It's not going to be you, right? But people have a hard time with statistics, right? They don't understand these things, especially these numbers that get, very, very large or very, very small. It's hard for them to take that into context. But for instance, hey, your chances of dying during the surgery are the same as if you took a, long car ride from, say, LA over to Orlando, right? Sometimes they can put it into context a little bit if you can kind of describe it a different way. Because again, to that patient, if they have a bad outcome, guess what? It's 100% incidence for them because they say it will happen to me. So that's why it can be kind of tough when you're trying to relate some of these statistics back to your individual patients there. And again, trying to frame it in a way so that they understand it as being an acceptable risk when you've determined to be acceptable risk, and trying to explain to them so they kind of understand that too. So as I mentioned, it's pretty difficult there to be sure you have the correct denominator when you're actually looking at risk here. So when you're looking at these studies, it's important that they have the right denominator. Who's the actual population that could be a risk for an event? So for instance, if I was looking at, say, pregnancy, the rate of pregnancy, say, in this PA class, so these 27 months, which I hope is going to be 0, for your sake, not for mine, I don't really care. However, how do I have to define the denominator? Should it include every single student here? No, because there's a decent percentage of you guys, or guys particularly, who are not going to be able to get pregnant, right? So again, making sure that people who are actually at risk for the event are included in that denominator, right? That's important. But then you have to get even more specific, because can every female necessarily get pregnant? No, so maybe defining a little bit more specifically, saying, say, age 15 to 44 may become pregnant. I always get really icked out because when I'm at the hospital and we get pregnancy alerts, anyone know how young they usually put those alerts at? Any guesses? 12? 8? Usually like around 9. Usually around 9 is when they put those alerts in, because it can happen, right? You hope it doesn't. I pray it doesn't happen to my 2 girls, but you never know. It could happen. But again, trying to define specifically who could get pregnant to being in that particular denominator right there. That's a patient population who may be at risk. And again, can any woman from age 15 to 44 get pregnant? Not every single one of them. That could be sterile for whatever reason. Maybe they had a hysterectomy. Maybe they had something else that keeps them from getting pregnant. So again, making sure you have that right denominator is really important. Again, looking at when that study we did in the journal club, notice how they were looking at patients, they were looking at students who had to be older than 15 in their definition, or to include in the study. And why was that? Why do they have to be older than 15? Yeah, because their definition, or they're younger than that, they're still at risk. Because again, their definition of early sexual first encounter was at below age 15. So if they're still 12, they couldn't be included there because they still had time to meet that definition, right? So again, knowing your denominator, knowing who that population is important to understand the kind of the outcomes of the studies. So again, looking at, say, the truly susceptible population may be really difficult to know when you talk about things like infectious disease. So just because you're exposed to TB, does that mean you're going to get TB? Absolutely not, right? Because again, you have a healthy immune system. There could be lots of other factors that are playing a role here. And so again, looking at this, only maybe a particular percentage of people may be actually susceptible to it. And even those who are susceptible, even a smaller subset of those are actually going to get disease. And even a smaller subset of them are actually going to become ill. And even a smaller subset of them may actually die from it, right? So again, sometimes you're looking at subsets within subsets of these things. And so it's important to kind of determine, like, what's your denominator going to be? What are you actually trying to define here, right? As I mentioned, it's pretty complex here. So again, there's numerous subsets here. So again, who dies from it, who gets ill, who gets infected, who's exposed, and then who's ultimately susceptible. Each one of these is a subset of the next one. So again, your denominator changes each time there. Looking at different comparisons, you'll find they can tell you different things, right? So again, looking at the proportion of clinically ill persons who die is called the case fatality ratio. So what's your denominator in that case? Was people who got clinically ill, not just anyone who was exposed to the disease, but people actually developed the disease and then who ultimately ended up dying, right? So that definition, that denominator is different versus, you know, say looking at the proportion of people who were infected versus those who got clinically ill. And the denominator here is going to be those who got infected. So the full population there, then looking at how many, what subset of those people actually went on to develop actual disease and actually got ill from it. Again, that's a different denominator there. So looking at that, you can tell different things. So for instance, the higher the fatality ratio, probably the more virulent the disease is, right? Versus looking at, say, how many people who were infected versus those that actually got ill tells you about the pathogenicity of it. So they tell you different things based off what your denominator is and kind of how you define those sorts of things there, right? So again, kind of gives you a pictorial example here. They get you know, kind of smaller and smaller pieces of the pie here, so you ultimately get to the smallest bit there, right? So each one of these can tell you a different thing when you define what your denominator is versus the numerator.
See how loyal we are to you?
It's awesome. It's great. I say jump, and you say ha ha ha. There you go. Thank you. Anyway, any questions from the first half? Anyway, all right, so we were talking about risk. Shh, bring it in. Okay, so we're talking about risk. We said risk is the percentage chance or the likelihood that an event's going to happen over a period of time. Again, it's important to know your denominator, which is your population that you're interested in. But there's going to be some limitations there. So imagine, for instance, that you had, say, 3 different nursing homes. They all have a 10% chance of mortality during that 1 year. Okay, it's not a very good nursing home, any 3 of them. But let's say they all have a 10% mortality. However, let's say that the death rates may change based on kind of what events are actually happening in those different nursing homes, right? So what you can see is that even though the 10% risk of mortality is the same between each of the nursing homes, you may find that the actual pattern can differ. And so being able to kind of to put a number to that, to actually show the difference between the 3, is going to be something that can help us out with that. So let me here. So let's suppose that with population A, so nursing home A, they had an influenza epidemic in early January. So their study period is going from January 1 to December 31st. In January, early that year, they had all their mortality happen right in that first month. So 10% of those residents died, and then they stayed alive the rest of the time period. Okay. For population B, they were alive the entire time until they had their flu epidemic at the December time point. At that point, all 10% of their population died off. Okay, and then let's say we have C, nursing home C. They did not have any epidemics. They had a pretty steady rate of death throughout that time period. Again, 10% in each one. So if you had 100 residents, 10 of those residents died in each one of these. However, the patterns are going to change pretty greatly here, and I'll show you the graph. But you're going to see that the risk is 10% regardless, but it doesn't really tell us anything about what that pattern was or how that risk or how those people died throughout that entire time frame. And so what we're going to have is what we call the rate. The rate is going to be able to help us kind of elucidate better how that change occurred over that time frame. I'll show you what that looks like in just a moment. Looking at this graph, you can kind of see here that we had, again, 90% survival for all 3 groups here, but you notice with A, we said that they had their influenza epidemic early on in the year, so all 10% of them died off pretty early, and then they stay pretty similar throughout. B, they stay pretty similar throughout, however, their other 10% of the mortality occurred right towards the end of the year, and C was very even all the way throughout here. Okay, so what you notice here is that the population change is different, whereas A had a lot of their population dip off at the very beginning. With B, they dipped off at the end, and C was consistent throughout. We're going to see that's actually going to change the rate that we're going to be able to calculate based off of this. So we can see, well, which one had the deaths very early on versus which ones had the deaths very late. And so that can help us to figure this out. So basically what we're going to do is, instead of just using the frequency, using the risk of 10%, what we're going to use is actually a different denominator. Instead of looking at the entire population, what we're actually going to use is what we call the mid-period population. Okay, the mid-period population is basically a surrogate for the average number of people that were alive throughout that time frame. Okay, So what you're going to see is when you go back to look at that graphic with A, B, and C, you're going to see that their mid-period population right around July was very different from one another. Remember who had the lowest mid-period population? It was group A, because again, older people died off very early on. The one who had the highest was actually group B, because the older people died off towards the very end. So by looking at different mid-period populations, this is going to give us an idea of the rate. And basically that mid-period population is an idea of the average number of people alive throughout the study period. Okay, and so basically when we're actually calculating this out, what we're going to do is take the numerator, which is the number of people who had the event throughout the year or died in this case here. The denominator is given our mid-period population, and then we're going to have a constant multiplier, which we're going to see what that is in just a moment here. I'll kind of define that in a second. So again, as I say, usually if you're looking at risk versus rates, they tend to be pretty similar with one another. Again, they should be less than 1, assuming that unless 100% of your people died or had the outcome you're looking at. And again, this is usually going to be for things that only happen once, right? So for instance, I wouldn't want to look at asthma attacks because that can happen several times throughout the year. Death is a good one because it's very dichotomous. You either had the event or you didn't have the event, right? And when you're actually looking at these numbers, you're going to find that, when you talk about these rates that occur, like you do talk about, we had 56.3 deaths that occurred this year. Does that make sense? Well, no, because you can't talk about a third of a death. Like, how do you only die a third of a time, right? I guess there's like a death by 1,000 cuts, and maybe you only had 333 cuts. Who could say? Yes, sir.
Heart attack, maybe you lose some of your heart muscle.
Maybe who could say, right? Maybe a broken heart, someone steals half your heart, and then I don't know. Anyway, but the thing here is we'll actually multiply by a constant, right? So basically we can either say multiply by 100, 1,000, 10,000, 100,000, and that way we can say that instead of having a fraction there, we can just basically say a whole number, and so it'll be kind of easier to talk about. So basically, you had 1 death per 1,000 people per year, right? Kind of similar when you talk about, having a 30-pack history of smoking or something like that, a 30-pack year history. Kind of similar to that point there. And so basically by using this, it also helps us to kind of compare apples to oranges. So if you had different population sizes, you can kind of multiply by the same constant to get a little bit better idea of that comparison between the two. So again, the value of the ratio doesn't really change at all. It's just that you're multiplying by that constant in order to give you a better idea, and you're not dealing with a fraction. It kind of makes better sense to people. So I'll show you what that looks like in a second. So for instance, when you're looking at, say, the crude death rate, shows why we would look at this. So for instance, in 2003, the rate of death in the U.S. was about 0.0086 deaths per year. 0.0086 percentage per year. So it's like, it's kind of hard to quantify, right? It's hard to kind of get an idea what's 0.0086 percent of the population dying per year. But it's easier if I multiply that by 1,000. I could say something like, well, it's 8.6 deaths per 1,000 individuals in the population per year. Okay, so I can imagine 1,000 people and say 8.6 of them died. Or what could I have done instead? I could have said by 10,000. I could have said 86 people per 10,000 per year had died. And again, it's important you have to include that per whatever that constant is to make sure you kind of know what you're comparing it to, right? You know what your total kind of baseline number is there. It's just a better, easier way to talk about these sorts of things. And so with rates, they can kind of be thought of the same way as kind of a velocity. So if you're going to kind of go back to physics, and you always wonder, why do I need physics to get into PA school? Here's one very small example where this actually comes up, but I'm just kidding. Physics are very important for all sorts of science. But anyway, so let's imagine you were to drive, say, 55 miles in 1 hour. What would you consider your average speed to be? 55 miles per hour, wouldn't you think? Right? Makes sense. Does that mean you were driving 55 miles an hour the entire time? No, you probably had to build up to 55 miles an hour, right? Or you probably had to stop and go traffic for a little bit. So you're probably going somewhat below that at certain points. You're probably going above that at certain points. But the average was 55 miles per hour. This is kind of telling us the same thing when you're kind of linking it back to the rates of events that are occurring in these cases here. This is what these rates are helping us with. So, and again, looking at this in a similar manner, the average rate of an event, in this case we're looking at death, could be equal to the total number of events for a defined period of time, right? So usually we say like over a year, over 5 years, whatever we define it as. And then we divide it by the population that was exposed to that event. So, and then we can say, okay, we have 12 deaths per 1,000 persons per year. Again, it gives us an idea of the rate. It gives us a better idea of that kind of that force of mortality for those people there. And I'll show you that when we're actually doing some comparisons here. We can go back to the nursing home example here in just a moment. But basically, another way you can kind of think about this is sometimes it describes the instantaneous death rate or a hazard rate. Basically, kind of the same thing when you're talking about just specific rates. So, looking at the nursing home example, we said what was the risk for death in all 3 of these nursing homes? that was 10%, right? So we know that 10% of those residents are going to die per year there, right? So that was our average. But we saw that the pattern changed pretty greatly, where they had the influenza epidemic at the beginning of the year, the end of the year, or they had no epidemic whatsoever. It's still 10% risk no matter what. But let me show you how the midpoint populations have changed that will give us a different rate, as we're going to see here. Looking back at this, we said that because A had a lot of their people die off early on, we saw their mid-period population is what? It's a lot lower than B or C. B, who had most of their deaths at the end of the year, had a lot of their people still alive at that point. So again, they have a higher mid-period population. So see how the denominators have changed? When you're looking at risk, your denominator was the entire population at the very beginning here. When you're looking at the rates, this is where you use the mid-period population. Okay, that's basically the main difference between how you calculate these. So when you actually calculate it out, you'd find that A is going to have the highest rate because it has the lowest denominator. Right? As the denominator is smaller, you're going to find that that ratio is bigger, so you're going to be having a higher rate than you would see with B, which had the largest denominator at that point, the largest mid-period population between the two. I'll show you those numbers here in a second. And C is going to be somewhere in between because, again, they had kind of the mid-period population. It was between A and B in those cases there. So again, a rate usually oftentimes can be a good estimate of risk, and sometimes they can be used interchangeably in some cases. That's mainly going to be, for instance, if the event in the numerator only occurs once per individual, right? So it's not something like an asthma attack that can happen multiple times, or ear infections or things like that. And then also if the proportion of people who are affected is pretty small, so say less than 5%. In this case here, you're going to see that the rate differs pretty greatly from the risk. But if it's a very small percentage of people who develop an event, say for instance like stroke or something like that, you may find that it's going to be pretty similar, and the time interval has to be pretty short there, because again, the longer the period of time you're running a study, you're going to find the mid-period population is going to get smaller and smaller and smaller as you go along, because again, the event is still happening to people as time goes on there. I'll show you an example of that in a moment. As I mentioned, as the numerator, if it's something that can occur more than once, so whether it's ear infections, getting the cold, asthma attacks, anything like that, sometimes what we're going to use is what we call incident density, and then we're going to use that instead of actually using a rate there. And so again, when you're looking at this, you're going to see that even though the denominator for a 5-year risk is the same as a 1-year risk, because again, that denominator is always going to be the very beginning population number there, you're going to find that the rate differs pretty greatly, because again, that mid-period population is going to get smaller and smaller the longer you're running that study for. So again, for a rate, the denominator is constantly changing, as I kind of already alluded to. As people either die or maybe they leave the study, you're going to find that's where you're going to find that mid-period population gets smaller and smaller. And so you can also have cases where people are kind of moving into the study. That would be a case where the denominator would increase. But again, something like death is usually not going to be happening too often there. But again, that rate basically just giving us an idea of the estimate of the average population at risk over that period of time. And again, whether it's 1 year, 5 years, whatever we define it as. So looking at this, we can find that if the interval is pretty long, we mentioned that risk is not going to be a good surrogate for rate and vice versa. Typically, you're going to be, mainly because that mid-period population is changing so much at that point there. And again, when rate and risk are very small, then again, the differences in the numerator don't really change that much. Okay, so looking at the actual numbers here, we can actually look at the different rates between the 3 different nursing homes we were talking about. Looking at population C, we saw they had a pretty even mortality risk throughout the year, and so again, their yearly mortality is 10%, just like it was for A and B there. But again, by the middle of the year, how many people, or what percentage of people had died at that point? It was 10% for the whole year. The midpoint should be 5%. Half of 10 is 5, right? So 5% had occurred, or 5% of the population had died during that by July there, right? So looking at the rate, we're going to find that the rate's going to be 10% divided by 1 minus 0.05, or that 5% there. So you find that the mid-period population is 95%, okay? Meaning if you divide that out, and again, I'm not going to have you actually calculate these numbers here on the test, but I just want to kind of illustrate how the denominator is changing here. You'd find that it ended up being 105.3 people per 1,000 persons per year. That means if you're looking at similar nursing homes and you had 1,000 people, you can say that in that year about 105.3 would die in that year time frame, right? That's the rate. Notice how it's different than the risk, which is just 10%. Okay. And again, we convert it from 0.1053 over to this 105.3, because again, that's a little bit easier for people to kind of think about as far as numbers go, right? They can think about it as whole numbers. That makes it a little bit easier for them. But again, the denominator is 0.95, because by that mid-period population, you had 5% of those people are already dead at that point. Okay. Now, looking at this, could you say, now, I guess another good thing to kind of think about, so say you had 10% mortality in that group's and that nursing home C, does that mean that at the end of year 2, only 80% of those people are still alive? No, because it's 10% per year, so that means that as that number gets smaller, it's still 10% no matter what, so that number of people are dying or at risk are going down similarly, okay? So similarly, you wouldn't think that if I had followed that nursing home for 10 years, at the end of 10 years, would every single person be dead? No, it doesn't really make sense. It's going to be 10% of whoever's left alive at the end of that year. So the question is, how do you actually calculate that? And this is where we get into a little bit more complicated math, but this is where we use things like logarithmic numbers, using the natural logarithm. So I'll show you the calculation in just a minute here. But basically, if you look at the risk over time frame, which you're going to find at the end of 2 years, 5, 10, and 15 years, you're going to see it's going to go up. Here we see 19%, 41%, 65, and 79. I'll show you a table where that makes more sense in just a moment here. But again, you just can't add up 10% per year because, again, at the end of that 10 years, you think everyone would be dead. That's definitely not going to be the case there, right? So looking at that, and again, looking at the risk, the cumulative mortality risk over years, this is where you have to get into using the natural logarithms. Let me show you what that looks like. Basically, and again, I'm not going to make you calculate this, but at least want you to know kind of what the numbers are going into it mean. Basically, what you're going to take is R is this risk, which in this case we said was what? 10%, right? 10% per year. And then T is going to be the total number of years that you're actually looking at. And then E is the base of natural logarithms. Again, you can choose your calculator for this to kind of get all that. And then this mu here is the mortality rate. So, and again, this T right here, I'm sorry, it should be the actual calculator risk we're going to be getting from it. Mortality rate we're going to see is what we calculated from that before, that 1.1053. So when you actually calculate it out, you can actually put in how many ever years you want to look at and see what that total cumulative risk is going to be. So we mentioned that when you thought from 1 to 2 years, you don't want to think it's going to go from 10 to 20% mortality risk. It's going to go down over time because the number of people who are at risk for dying are going down as well. So at this point, you're going to find that in 2 years, you should have about 19% of those people have died off. Okay. As you continue on, say you go down to 5 years, you notice it's not going to be 50% of those people are dead because again, that number of people at risk gets lower and lower. It's only about 41%. And then I go all the way out to 15 years. You'd expect that everyone should have died by 15 years, right? No, it's still 10% per year based on the people who are still there. It's about 79%. Okay, so again, this is something that you have to take into account. Again, when you're looking at these things over time, these studies will usually report out numbers kind of like this. But it's good to know how they get these numbers, not just to think, okay, well, it's 10% per year, so after 10 years, everyone's dead. That's really not the way it works. So that's how we come up with the cumulative risk that happens over that time frame there. Okay. So again, looking at kind of validating, making sure that rates make sense. For one thing, you have to make sure that all the events that occur in the numerator have to be able to happen to people in the denominator. And that kind of goes back to saying, like, okay, well, is the population we're looking at actually at risk for the event occurring? So again, I can't use the entire U.S. population looking at pregnancies because not the entire U.S. population can get pregnant, right? So you need to make sure you're being a little bit more specific. Or, say, for instance, looking at cervical cancer rate in men. That doesn't really make sense because they have no cervix. And so also when you're trying to make comparisons between groups, that's what we actually really care about, is being able to compare different groups together or to compare interventions. You also have to make sure that the constant multipliers are being used have to be the same. So that way I can say per 1,000 persons per year for both comparisons, not just one's per 1,000 people per year, one's per 10,000. That way it's not really a fair comparison. Time intervals generally need to be the same. You need to make sure that between the different groups that the actual diagnosis or the definition has to be the same. Because if I change that, then you can find that the numbers aren't going to be very accurate. So for instance, if I'm trying to look at, say, something like, the diagnosis of MI based off of like positive troponins in the US compared to, say, maybe a third world country, is that going to be apples to apples? Maybe not, because they may not have access to the same labs that we do, may not be able to have the same kind of diagnostics, and so in those cases it may not actually be the same there. So again, you want to make sure at least your definitions are going to be pretty close together, or the way they diagnose is going to be meaning the same definitions. And so, as I mentioned, looking at that example of looking back at the 1800s, no one got diagnosed with MI because they didn't even know what an MI really was back then. Just said, oh, they died of acute indigestion, which I would have died of that a long time ago had that been the case, right? But fortunately, nowadays we're able to make better comparisons and we're able to make better diagnoses here. So again, the definitions really change over time. So it's hard to compare things happening back in the 1700s versus now because so much has changed. Now, does that mean that everyone who has acute indigestion is having an MI? No. And then everyone who has an MI, did they actually get diagnosed with acute indigestion? Not necessarily. So again, that's why definitions really make a difference there. So again, you have to consider things like, okay, how are these things being defined? This is where things like ICD-9 codes and ICD-10 codes really come into play here, because that really provided a lot of standardization for actual diagnosis of things. So in a lot of studies, what you're going to find is when they're pulling things like people who had this definition, this ICD-10 code, got classified as having an MI, right, or whatever the case may be. That really helped out a lot. So that way you weren't just going off of random documentation to figure out, yes, this person had this outcome, or no, they did not have this outcome. So, for instance, like when I was doing my study in fellowship and I was actually looking at outcomes in patients who had coral snake bites, it was really painstaking because I didn't have something nice like an ICD-10 code to go off of. I had to go off of basically free-handed charts and go through, okay, did this patient get intubated? Did this person end up receiving antibiotics? Did this person, get antivenom or things like that? That made it much more difficult to go through. But with things like ICD-10 codes, makes it much easier to classify things appropriately, make sure things are getting diagnosed by the same definitions, etc. Again, ICD-10 is one thing you're going to be using most frequently. It's the most recent one that came out. Okay, so a couple of different definitions here. So now we're looking at incidence rate. So incidence rate basically means it's going to be the number of incident cases over a defined study period. And again, this is where we're typically going to be using one of those constants that are going to be expressed there. That's kind of what we're looking at the case of those nursing homes. We're looking at new incident cases of death over a period of time there, but using that mid-period population to make it a rate rather than just a risk there. The prevalence rate actually tends to be a proportion. So instead, it's going to be basically the proportion of people with a defined disease or condition at the time when they're actually studied there. So it's really kind of more proportion rather than as actual prevalence like you would think of like a normal point prevalence there. But basically we can apply this to other risk factors, maybe to other diseases or other conditions, kind of gives a better basis for comparison there. We're not going to use prevalence rate too often, but it would definitely use incidence rate in some of the examples we're going to be looking at coming up here. Then incidence density is going to be helpful for something that can happen, say, multiple times to one particular individual. If you're looking at, say, something where you have different time frames that you're actually looking at, maybe people are followed for different periods of time. A really good example of this would be patients who, say, had recurrent ear infection after getting a TNA done. So let's say we followed one patient for 13 months, we followed one patient for 20 months, and one patient for 17 months. And we followed, and they had, amongst the 3 patients, they had 5 ear infections. We could basically say they had 5 infections per 50 person months, right? So in some cases we have those things that can happen multiple times. You can just look at the density of the incidence based on the period of time you followed those people for, right? Or you can just multiply it by and say, okay, well, you'd have 10 infections per 100 person months. Really, as long as the ratios are the same there, it really doesn't matter how you define that, right? As far as your person months go. That makes sense? You can take the total amount of time people are followed by the total incidents that occurred during that time frame. Again, useful for things like MIs. It can happen more than one time to a particular individual. Okay, now we use rates and risks, so you're like, okay, we talked about all that for a while, like what the heck does it even use it for? Well, they're good for making kind of 3 types of comparisons here. The first one is going to be if we're comparing an observed rate or risk with, say, a target rate or risk, right? So for instance, if we're trying to shoot for a particular goal of, say, a certain rate or risk of infant mortality, we can compare what's actually happening versus what our actual goals were and see whether we matched up or not, whether we fell short of our goal, whether we exceeded it, or whether we met it. That's one good way we can use these goals maybe set by the government or set by a certain organization and kind of compare what actually happened versus what our goals were set at. The most common thing you're going to find is you're comparing 2 different populations at the same time, right? So again, if we're looking at, say, the incidence of a certain disease state that could be caused, prevented by a vaccine, comparing 2 different populations, one got vaccinated regularly, one didn't. You can look at things like, clean water programs, between different organizations or different populations, any kind of things like that, where you want to compare 2 different groups at the same time. It can be very useful for using these rates. And I'll give you a few examples of that in just a moment here. But again, one of the big concerns is making sure that they're being defined similarly. You're really comparing apples to apples together, those cases. And then the third time could be where you're looking at different populations at different time periods. So again, if I was looking at, say, cases of MI in the, say, 20 teens versus if I was looking back in the 1990s, again, you have to consider, though, that usually over time, what happens with your diagnostics? Usually get better, right? So again, this could be one of those things where maybe we're better able to diagnose things like MI nowadays than we were, say, 40, 30 years ago. But again, you have to kind of compare those and see, like, what was the case at the time? Are the definitions, how do they change over time, especially in terms of diagnostics go? Again, less common, but the most common ones are going to compare two groups together. So when you're getting into rates, there's a few different kinds we'll talk about. There's going to be what we call crude, specific, and there's going to be standardized rates here. Now, when I say crude, what do you think that means? So that's my jokes sometimes. Basically just the raw numbers, right? So just kind of a raw comparison of one group versus another, wherever the case may be. You're going to find, is that always going to be appropriate? Not necessarily. I'll show you an example why that not be the case in just a few moments here. But, and again, imagine if you were to take a population, you divide it up into, say, more homogeneous subgroups, right? So imagine you were to base it on particular characteristics. So I wanted to break down a population based on their age or sex or race or risk factors, comorbidities, anything like that. You can calculate individual rates amongst those groups there. And then when you do that, those are called specific rates, okay? So if I can say I have an age-specific rate or a sex-specific rate, that's just going to be when you take one of these crude numbers and then break it down into an individual characteristics of that population, right? So it's kind of a subset there. We'll talk about standardized rates a little bit later. But that's the main difference. So crude would just be the entire population. Specific is where I'm going to say base it off one particular factor or one particular characteristic of that group. And then we'll talk about standardized in just a few minutes here. Basically, crude rates, they're certainly valid, but they can oftentimes be misleading, right? And so I'll show you an example of this where if you were to imagine three countries, imagine you had Sweden, you had Ecuador, or the US, and you were to look at their highest and lowest crude death rate, okay? And when you're looking at this, you'd say, well, 2004, Ecuador ended up having the lowest crude death rate, and Sweden had the highest crude death rate. When you're looking at that, you may think, well, does that make sense? Would you think the death rate would be higher in Sweden versus Ecuador? What do you think? Well, I think so. You think like things like access to healthcare might be a little bit better in Switzerland, a little bit less in Ecuador. But when you start to dig down a little bit more specifically into the specific categories, you're going to find that the mortality rates are going to actually differ, and the life expectancies differ quite greatly between the groups here. You're going to find that in Ecuador, they had the highest age-specific mortality rates and the shortest life expectancy, but then Sweden had the exact opposite. However, you have to look at the breakdown of the population there. Which one do you think has a younger population, Ecuador or the Sweden? Probably Ecuador, right? If people are living for longer in Sweden, they're probably going to have a much older population, right? We just know that older people they like to die on us, right? So again, it's just what old people do. I hate to tell you. Anyway, but hug your grandparents when you see them at Thanksgiving. You should. Anyway, so again, when you're just looking at the crude rates, it's not really going to take into account these different age breakdowns. It doesn't take into account the percentages of people that fall into the elderly category versus the young category versus middle age. So let's look at that. So by looking at the distribution, you're going to find that the Ecuador, they had a median age of 23. Okay. Versus when we look at something like Ecuador or Sweden, we're going to see it's a little bit different. You know, the birth rate tends to be relatively high because they have a larger percentage of young people who are reproducing. You're going to find that the crude death rate tends to be pretty low. So the younger the country tends to steer, you're going to see that the crude death rate tends to be relatively low because younger people tend to stick around. They don't die as frequently. When you're looking at an older population like Sweden, you're going to find that they have a relatively low crude birth rate because they have a larger percentage of people who are kind of aging out of that category. And so you expect a high crude death rate, but because of the fact that they have better access to healthcare and things like that, you're going to find that that they don't have as high of a death rate when actually comparing it based on the age populations. And so we can actually break it down by looking at the specific death rates amongst those groups there. We can actually make a little bit better comparisons between the two together. And so we'll look at some examples of that in just a moment here. So things like that you have to control for age. So looking at the crude death rate, for instance, looking at Ecuador, and again, this is going off 2004, so it'll probably change a little bit. You can see that the crude death rate is 4.6 versus 8.3 versus 10.4, right? However, when looking at the average life expectancy at birth, you can see it's going to skew a little bit lower for those in Ecuador. So again, by breaking out the age into specific groups there, you get at least a little bit better idea when you're making these comparisons. So Again, why not avoid crude rates altogether and only use specific rates? Well, sometimes it can be useful where it's not possible to use specific rates, right? So again, if you imagine if the frequency or disease is maybe unknown for subgroups of the population, so maybe you don't have access to the data that says when these different age groups, maybe based on sex or based on comorbidities and things like that, may not be very useful. If the size of the subgroups, if you don't really know what the denominator is, may not be able to do that. And then if the number of people at risk is very small, and you may not find they have very stable estimates of the specific rates. So again, those are cases where crude numbers are still going to be useful, even though you'd like to have specific rates whenever possible there. Because again, you need to control for those factors, otherwise they're just kind of confounding the data and skewing it one way versus another. So again, when we're looking at this, even though you're basing the effective age, you're trying to control for that. The way we can do this is actually what we call it using an age-specific death rate. And so we're basically going to take the rate and compare different age groups to one another. And basically the way we're going to do that is taking the number of deaths in the people of a particular age group. So let's say we did 18 to 24 as a particular age group, and then we look at the mid-period population there, right? And this is what's going to make it a rate versus just a risk in these cases. And then a lot of times you multiply by the constant, whether it be 1,000, 10,000, 100,000, whatever you like. So, and basically when you take all those breakdowns of different age groups, if you add them all up together, you should get the same crude death rate, right? Because again, these are just subsets within that population there. And again, if you were to look at the underlying thing here, you'd see that the individual weights, proportion of each specific age group, whether it be, say 18 to 24 is only 5% of the population or 10%, whatever the case may be. And then look at the rates, multiply that together. By adding them all up, you should be able to get that summary, that crude death rate, as we'll see there, for the entire population. And so again, by adding everything up together without taking into account the weights of those specific groups, you're going to find that it can be a little misleading when you're just using the crude rate there. Okay, and again, I'll show you a very specific example of this in just a moment. Okay, so imagine, for instance, you were trying to compare, say, the death rates between different hospitals. Okay, and a really good example of this is something like if you were to compare, say, Winnie Palmer versus looking at, say, Nemours, looking at neonatal death rates in the NICU. Okay, so if you'd imagine, who do you think has a higher death rate in the NICU? You guys might not know. I may be biased, and I may have, well, that Winnie Palmer, that place is no good, right? No, I don't really care either way. But what you find is that we're looking at specifically a children's hospital versus a women and children's hospital, where are all the babies being born at? How many births do you think we've had at Nemours? Thankfully, none, right? We're just not equipped for that. We're a children's hospital, not a women and children's hospital. So that means is that our NICU kiddos are either being brought in through the ER or they're being transferred in from other hospitals that could not care for those children there. So what do you think about the illness, relatively speaking, of our kids that get sent to the NICU versus, say, at Winnie Palmer? They skew towards more sick, right? Because they're getting a ton of healthy babies in addition to all the really sick ones. We're getting all the sick ones kind of getting transferred to us, right? They're kind of pre-selecting for those. So you'd have to take into account these different factors here, because otherwise it would look like we have a lot worse death rate there, right? Because again, we have all these really sick kiddos versus over at Winnie Palmer, all the healthy ones that kind of diluted out the numbers a little bit. So these are examples where you're looking at things like, a trauma center is probably going to have a lot higher death rate than if you were to look at a hospital that did not have a trauma center. But again, they're getting sicker patients into them, so that makes sense. And so again, you have to be able to compare apples and apples together to make a fair comparison. So by using a standardized rate or an adjusted rate, basically their crude rates have been modified or adjusted to account for some of these factors here, right? So again, looking at age or looking at other characteristics, maybe if you're looking at NICU kiddos, maybe like their APGAR scores or who knows what you could look at. But basically, this will help you to perform more valid comparisons between groups there. And so again, to get the summary death rate that's basically kind of free from these age bias, basically what they end up doing is making these age standardized crude rates, and they have a couple of different methods they can do it with, either direct or indirect, and we'll see what those look like in just a moment here. But again, you can adjust these standardization processes and apply it to death rates. It can be used really for any type of rate whatsoever. So whether it be incidence of MI, whether it be incidence of HIV diagnosis, whatever the case may be. But again, we use it in death most commonly in these examples. So looking at the direct method here, we're going to find this is going to be most commonly used to try to remove any kind of biasing effects from the different age structure. Kind of going back to that example of Ecuador versus, say, Switzerland, we're trying to make those age-adjusted rates to try to take into account the different weights of the age groups there. And so basically what we can do is just take the age-specific death rate and then multiply it by the kind of percentage of each group within that, right? So again, if you have 40% of the population is considered to be elderly, you'd multiply that age-specific death rate times that 40% in order to get the new adjusted number. And so again, by having the age structure of the standard population, we know it's not going to be the same no matter between different populations. You're able to take out the weight of this and try to make fairer comparisons between the two there. And so again, when you're using a standardized population, it's usually kind of a fictitious number. Usually trying but the rates are going to be the same basically between the two comparator groups. You're going to be able to kind of adjust for those things, apply it to this kind of this fictionalized sort of denominator, and get better comparisons out of that. And I'll show you that example in a moment. But it's like, imagine if you're comparing two different cities together and trying to get an idea of like, okay, what's the death rates in say Flint, Michigan versus Orlando, or the case may be. You want to try to make it more fair comparisons. So I'll show you what that looks like in just a second. Typically what you do is you'll take the total expected number of deaths from each of the comparison populations and basically try to get the standardized crude death rate, and then you're going to be able to compare that with the one from the other standard population as well. And by doing this direct sort of this method here, you're able to get these sort of standardized rates that are fictitious, but they're a good kind of like what if sort of example, right, when you're trying to make a better comparison between two different groups here. And so an example here, we'll show you on the next slide. So again, imagine you have two different populations. We're going to have population A and population B, and we divided them up into young, a middle-aged, and then older people. Okay. Again, the ages don't really matter, but just know we kind of broke them up into these three categories here. We came up with an age-specific death rate for each group. And what you notice is that in population B, it's actually twice as high as that for the corresponding groups in population A. Okay. The difference that you're going to see is that the actual percentages within each of those age groups is going to differ a little bit between the two, as we'll see. So we can actually look at the actual numbers here, and it's going to look like population A has an overall higher crude death rate than B. We're actually going to see that when you make it and standardize it, you're going to find this not actually the case there. So let me show you what that looks like. So again, this looks scary. Looks like a lot of numbers. Let me kind of work you through it a little bit. Okay. So imagine we have population A here and population B. Now, normally when you're trying to figure out what the actual crude death rates are going to be, you basically have your different age groups here, young, middle-aged, and older. And notice here that both total out to be about 10,000. Okay, so it's going to be our denominator in each of these cases here. Notice that you have different percentages of the young, middle-aged, and older here. So about 50% are middle-aged in population A, 50% here in population B here. And look at the age-specific death rates. Notice you're going to be multiplying it by, in this case, it's 1% for the middle-aged group. It's 0.1%. In the young group, it's 10% here in the older group. And you just multiply these out, right? So 4,000 times 0.1 is 400. And basically, you're just getting the total number here. And when you look at it, you can see, okay, it's 451 deaths per 10,000 individuals, or about 4.51%. Okay, so that's for population A. They do the same thing for B, and you see 3.81%. So you look at it and you're like, okay, well, it looks like more people are dying. You know, the death rates are higher in population A than is for B. However, when you actually look at the death rates, you see here it's actually doubled. So what we can do is we can actually try to apply it to the standardized sort of population. Again, it's kind of a fictitious population. We can apply it there. And basically when you're doing it, we'll take this 10,000 and kind of add the two groups together. So basically we'll have 20,000 people. And by comparing it to one another now, you see by multiplying it out, you see they actually come up with 3.03% versus the 6.05%. So by doing that, by applying it to the standardized sort of population here, you actually get a better idea of what the actual death rates are between the two. And you see like, okay, well, I see here that it actually looks like population A has lower death rates than population B has. You would assume that population A is probably healthier than population B is. But you only knew that once you actually applied it to the actual standardized sort of fictitious sort of population of this 20,000 here. So just know when you see this, that is a better way to make a better comparison between the two groups rather than just kind of taking it at face value here. Okay. So again, this is the crude death rate we came up with versus looking at the standardized death rate. Make sense? So again, just kind of work through it again. You kind of see how the numbers kind of add up. It's pretty easy math for the most part, but it's just an idea of like, why am I actually making these comparisons and what am I actually doing here by changing this over to 20,000? It's just standardizing it to make sure I'm applying these same rates to the actual, this kind of fictitious population, see what would happen if population A and B both had 20,000 people in them, what it would actually come out to be. Okay. There's some indirect standardization processes that can occur here. Oftentimes this is going to be if we have no idea what the crude death rate is or the age-specific death rates are for a particular population. So again, if we don't have that access to that data there, we can use this kind of indirect method here. And basically what it's going to take is, and the example we're going to use is, these patients or people who are working on, say, an offshore oil rig, where we didn't know what their age-specific death rates were, and then we're going to compare them to people who are on, say, mainland U.S. and say, like, okay, well, what would happen if you applied the typical death rates in the U.S. and then applied them to the people on this offshore oil rig, how they would actually compare to one another. Sort of an indirect method, but it still gives you a good idea of what it's going to be. So I'll show you what that looks like for in just a second on the slide. But basically, we're going to take the U.S. death rates, apply it to what it would look like had you apply the same numbers to the age breakdowns of the people on the offshore oil rig, and then see how the numbers actually compare. I'll actually go over the graph and show you what that looks like. But again, it's just kind of a what-if analysis. It's not actually etched in stone. It's just a good idea to try to make a better comparison than just looking at individual numbers. Anyway, what they're actually going to come up with is what we call the standardized mortality ratio. And again, we multiply it by 100. That's just a constant to try to make sure we're not dealing with fractions there. So I'm going to show you what that looks like in just a second here. Okay, and again, it looks like a lot of numbers, looks a little scary, but it's actually pretty straightforward when you look at it. So again, looking at men in the standard population, again, this is like people who are men who are living just on U.S. main shoreline, right? Looking at the proportion of the standard population, so people who are young, middle-aged, and older, you see the percentage breakdowns here. So about 40% of the population fits in this young category, 30% in the middle-aged, 30% older. Okay, and looking at their age-specific death rates, if you were to actually apply that through, you can see here for 100,000, you have about 334 people on the U.S. men dying. Okay. Now, if you were to look at the people who are working on the company and on the offshore oil rig, again, notice here how the numbers are actually skewing. There's 10,000 people here, but a lot of them are skewing more towards the older individuals, right? So they had about 50% of them who are fitting this older category versus only 30% when you compare to the general U.S. population, right? We don't have the standard death rates here because, again, we just don't have access to that information. But the idea is we have this number here. We have this observed death rate. What would happen if we were to apply these numbers over to these individuals? Well, how would that actually compare? So when you do that, you'd end up seeing here that, okay, well, if I applied this 0.001, 0.001, and 0.01, I should say, to these groups here, you'd actually find out that you're actually comparing this 53.2 out of 10,000, or basically you could say by this constant 532 out of 1,000. So looking at that, we can take this 480, which is the observed rate, versus what the calculated rate was, or this idealized rate if we were to take the U.S. data and apply it to these people, and see what you actually come up with. And so again, looking at this 480 divided by that 532, basically what you end up getting is about 0.9. Which means is that the guys who are actually on the offshore oil rig, they had about a 90% or 0.9, so they're actually less likely to die. They're actually maybe healthier than people who are actually the men who are living on the shore, essentially. Okay, so again, it's a fictitious sort of number here, but it's our best way to get an estimate of actual death rates for these guys compared to people who are actually living on land, right? So again, it helps us out with things like, like insurance companies, if they're trying to figure out kind of like risk for people dying in a particular population or in a particular line of work, whatever the case may be. They can be somewhat useful. You'll find them in all kinds of epidemiologic studies that are being done out there as well. Okay. Okay. You can also look at things like cause-specific rates, right? So again, this could be something where looking at the number of deaths due to a particular cause, again, it's just a different subset rather than just looking at deaths in a particular age group. Especially when you're looking at things like risk of death due to MI between various countries, right? So this is able to kind of give you some better comparisons between those two there. Can be very useful. And again, kind of the same general calculation here. You're still going to have the numerators define whatever the number of people that died based on that cause, divided by your mid-period population times your constant, whatever happens to be. So looking at this, I want to show you a slide kind of looking at leading causes of death in the U.S., say comparing 1950 to 2000. So again, this is that other kind of third comparison where we're actually looking at different time frames, but it's the same population essentially. And so you're typically going to find that this information is maybe not super useful because, again, diagnostics have changed pretty greatly here. But you're going to find it can give you an idea of at least somewhat trends as far as the death rates or the cause-specific death rates, how they change over time here. And so, for instance, if you're looking at, say, 1950 here in this category versus 2000 in this column here, you can notice here that things like cardiac diseases. So the rate of death per 100,000 is going down here. And again, a lot of it could be based on the diagnostics and the definitions here, but again, treatment is getting better for cardiovascular disease, right? So again, you'd expect that number to go down. Most of the things tend to go down. What do you kind of notice about things like HIV? Why is it 0 here? It was never, it wasn't diagnosed at the time, or was never existing at that time. So again, something that could not be diagnosed. So of course, that one's going to go up. And so again, you can look at all causes here. It's okay. It looks like our all-cause mortality is going down. Population is living for longer. We tend to be healthier in, say, 2000 versus in 1950. Okay, so that's going to be a cause-specific sort of death rate. Now, let's look at something kind of a good example of looking using infant mortality rates. You guys have old pictures that were on there. I realize I should probably include both my children, because this time last year I only had one child, but now I have 2 children, and so this is them just recently. This is on a daddy daycare weekend, but anyways, that's Lily and that's Phoebe. So one of the things that you use a lot of these death rates for is actually with infant mortality rate. We said, why do we look at infant mortality rates? Because it kind of tells us the overall health of the population, right? Because it's a good surrogate, because looking at the health of a baby is also looking at the health of the mom, right? So again, looking at things like the maternal care that was being received, because again, if the mom is using a bunch of drugs and alcohol during the pregnancy, the kid's probably going to do worse. They don't have a lot of good prenatal care, the kid's probably going to do worse. And so this is where you can use a lot of this information and then compare it with other countries. Because again, usually birth rates are usually pretty accurate. We usually have pretty good reporting of a lot of this stuff. And so that can be very useful for making good comparisons between countries. So looking at this, we can see that the international definition of a live birth is any delivery a product of a conception shows any sign of life after complete removal from the mom, right? So it can be anything from a breath, a pulse, anything like that can be considered life. And so we're going to look at deaths in different time periods. And again, talking about baby deaths is not usually like a very uplifting subject to leave you on a Friday. But again, that's why I include pictures of them, because they're very uplifting. They're so cute, right? Anyway, so you can categorize these things as either early, intermediate, or more late fetal deaths here, right? So in early deaths, you think it'd be kind of a surrogate of what? Probably prematernal or maternal care during the gestation period, right? Versus if you're looking at, say, late fetal deaths, it could be more related to how well the infant was actually taken care of during that first year of life. And so you're going to find that, early fetal death, probably better known as a miscarriage, is going to occur when the fetus is delivered within the first 20 weeks of gestation, right? It's actually, baby was never born in this case here. Looking at some of these different agreements, again, to kind of standardize these definitions here, they consider an intermediate fetal death as one that's going to be delivered between 20 and 28 weeks, and then a fetus born dead at 28 weeks, or greater is considered a late fetal death, again, better known as a stillbirth in these cases here. So again, they have different definitions for these sort of things, and again, if you get into this research, you kind of get a better idea when, get more used to dealing with the lingo here. Again, we consider an infant death to be any death of a live-born infant before the first birthday, because again, we said that an infant is considered what? What age? Yeah, 0. Well, basically 0 to a year is considered an infant. A neonate is considered what? The first 28 days of life, right? So again, that first month or so is when that neonatal period, and typically the definition goes to 28 days here. And then they also talk about the postnatal death period being after the 28th day, but before that first year, right? So again, there you can get into various breakdowns here, and they kind of tell you different things about as far as whether it is more to do with maternal care, whether it's more to do with care of the baby after it's born, different things like that. And again, you can come up with these different rates here, basically by coming up with, say, for instance, the crude birth rate is just the number of live births you have divided by that mid-period population here. And again, you can multiply by 1,000 and compare different countries to one another. And again, because the health of the infant is very sensitive to maternal health, because mother's nutrition, tobacco use, illicit drug use, all sorts of things like that, again, it gives us a good idea of how well we're taking care of the mom. So hopefully the baby should be doing better, the better we take care of the mom, right? And again, this is available in most countries. Very good to make these specific rates compared to one another. And again, get an idea of how, say, the U.S. is doing versus the other developing countries, right? And again, a lot of this information is taken from a lot of vital statistics reporting, some of those reports we talked about from the very beginning of the lecture here. And again, looking at this, looking at infant mortality rate, you can basically calculate it. Again, defining what your numerator is, in this case, number of infants less than 1 year of age, because again, infant is a whole year period, divided by the number of live births, right? So again, looking at what your denominator is, and then what your numerator is very important to make the right comparisons there. Most infant deaths, if they occur, typically are going to be during the first week of life and are either due to something like prematurity or maybe some kind of intrauterine growth retardation or something like that. Again, any of these things you can kind of considered, it could be due to congenital anomalies, things like that. But again, you can look at these early deaths, and I can give you some clues as well, kind of what's going on as far as maternal care goes during those early stages there. And again, looking at this, again, it's important to consider what your time frame you're actually looking at over. Sometimes it's good to look at longer time frames, especially if you're dealing with very small numerators here to get more kind of stable numbers over the long run. But again, if you're looking at neonatal versus postnatal mortality rates, again, just look at what your numerator is supposed to be versus what the denominator is going to be in here. In this case, looking at the neonatal rate, you just look at those that were dead within the first 28 days divided by the total number of live births, right? So the denominator doesn't really change here. Now notice here with the postnatal period, we're looking at the number of deaths between 20 and 365 divided by the live births in total. But why do you subtract out the neonatal births or deaths there? Because again, these people are not at risk because we're looking at the post-neonatal period. So we're looking at from 29 days basically to 365. So again, you want to include those neonatal deaths that occurred during that first 28 days there from the whole live births. So again, it's just a matter of defining your denominator a little more specifically. Again, looking at the number of neonatal deaths is pretty small, and again, as is true here in the U.S., typically less than 5 per 1,000 births. Sometimes it's good to follow this formula for these cases, kind of looking at things that are going to better reflect maternal care. Looking at the average or the approximate post-neonatal mortality rate, typically just take infant mortality rate minus the neonatal mortality rate. That's usually pretty good for most cases, especially when you have a very small numerator, as in the U.S. here. And again, the neonatal mortality rate is a better reflection of, say, maternal care prenatally versus the post-neonatal mortality period is a better idea of what kind of the quality of the environment the kid was brought into is going to be, right? So again, if they were maybe poor nutrition or had poor access to medical care, things like that, that's usually going to be a better reflection of that. And again, pregnancy, we kind of consider this to be a normal biologic process for the most part. And again, looking at the pregnancy itself, you can see, the different complications that can come about from. We just know that it's kind of a risky prospect in general, either due to risk of hemorrhage, infection, etc. And so knowing that this can be complicated by a lot of other disease states as well, we can look at things like non-pregnancy related deaths versus divided by the number of live births, and this actually gives us a maternal mortality rate here. And again, that tells us what kind of complications are occurring here. Is the mom sicker in a particular country versus another? It can give us some information about that. Okay. And again, looking at the equation, basically is based off the number of pregnancy-related deaths that occur here. And again, looking at a death of a pregnant woman or one who's recently delivered, not usually considered pregnancy-related there in those cases. So again, you have to consider excluding things like an automobile accident or homicide or something like that. So again, looking at your definition, make sure they're excluding the right kind of people. Make sure you don't include kind of unrelated sort of deaths there. And again, most of the time we're going to use 100,000 as our multiplier here. That's pretty consistent amongst various countries, and again, that gives us a good whole number to deal with in these cases here. So 8.2 versus just 0.82, say maternal deaths or something like that. Okay, so again, just an example of how we use rates, how we can use rates in the real world, kind of compare different things and maybe health education initiatives or compare between different countries, things like that. Again, not to try to bum you guys out any more than this lecture probably already did, but it's just an idea of the real world applications thereof. Okay, so any questions I can answer for you? Your heads are spinning. Fantastic. Should I check the sticky board?